just from an exam. Just to allocate patients and see what's wrong and
You're going to have to learn ecology.
Is it in October?
This ain't but it is usually in the fall.
Yeah, that's right.
Except for the one here. It was great, actually. That's deep.
And I beat just for asking questions so we can review all of them. You can say how many of course you guys have to
By the way, copy me.
all of them and then you can do extract the data? We already have the data.
no, I mean, what do you
Like I spent almost 3 days trying to come up with suitable ideas to see how can we make this together, and there's no way I can achieve this goal, so I stopped. The question seems very broad. I tried to put my things together.
You know what I told you what I'm doing.
But I mean, I guess it's every week.
Yeah, they packed it all up.
I don't know how can we achieve this goal. I mean, achieve this question. Probably we have more some sort of question. The idea is for instance, if you want to see versions, how many of them are prophylaxis. Although it doesn't make huge questions, but we need a qualitative project to see that, and then based on that we can.
Just a brief. Yeah. And now they just so I get extra yogurt. Somebody.
I used to pack breakfast every single day. Today I didn't pack.
And they go.
Well, how about on the menu? There's none on the menu. John, you're ready.
Whenever you are, sir.
Good.
Was that good?
Happy New Year.
All right, let's everybody take a seat. A little bit of a rocky start this morning because yesterday was university holiday. And normally the announcement of this session would go out, but it didn't go out smoothly. So I don't know how many people are on our outside audience. But most importantly, we have our speaker who's been with us 5 years. Maybe 6 years, and always gives a brilliant presentation, updates us on things that may not be practical necessarily in going back to your office in Allergy, but of worldwide importance as just doctors and human beings. So I always enjoy this presentation. So John Lynch is going to update us on allergy, an update for Allergist in 2018.
Thank you.
Thank you.
Thanks, Len. I like the beard, by the way. Sure, I do the same thing.
Yeah.
You know?
Well, yours isn't all gray.
It's starting.
Okay.
It's wisdom, right? It's wisdom teams.
I'm glad to hear that.
That's the genius part.
Yeah, that's the genius part.
Yeah, last week I was still a stable genius.
Right.
Okay, so welcome. Thanks, everyone, for asking me to come back again. As I mentioned when I first got here, the rocky start seems to be part of my presentation. True. But at least I am here. I didn't skip it. I think I did it the first or second time. I have no disclosures to make. So this is our 2016 topics: Zika virus update and microbial stewardship in the Allergist, the cure for Clostridium difficile. I don't think I ever really got to that last part. We talked about the first two. 2017, there was the update around Zika virus. What was going on around influenza? Ebola virus update. There's some nice little data on otitis media and the challenge of stewardship. And then I tacked on the cure for Clostridium difficile infection, which I don't think I got to again. Because I try to pack in always way too much. So this year, a brief perspective on infectious disease ecology, Candida, auris, the cure for Clostridium difficile infection, and then if we have time, depending on how things go, where are all these drug-resistant bacteria coming from? I did not throw the update on influenza because there's not really a lot of data out there right now. It seems like a pretty typical season for us. It's the same virus as last year, the H3N2. The big question people always ask me is how's the match with the vaccine, especially after the Australian reports around a 10% vaccine effectiveness number that came out of Australia earlier in the season. Right now, we don't know. It's a different continent, and when you switch the virus and the continent and the populations, the vaccine effectiveness tends to fluctuate a bit. But we'll see in the next month or so. I know at Harborview we're seeing about a 10 or so infections per day in our ED. So these are documented infections, and we're staying below that threshold of 10 inpatients per day, and not a lot of ICU patients. So I'm not sure what you guys are seeing in practice, but it seems like kind of a moderate to severe season this year with a classic traditional virus that preys on older folks and younger kids and those who are particularly immunocompromised. I know that I've heard data out of like Los Angeles and other major metropolitan areas in the United States that are finding big numbers, but around here it's sort of in the moderate range, at least in our experience. One thing I will note, in Harborview we saw a very early signal on influenza with about the same numbers per day of influenza diagnoses made RD, but 90% of them were in the homeless population. And whether this had to do with some disease dynamics or had to do with recent changes in our homeless populations and where they're being housed or not housed is unclear to me, but we'll work with public health on figuring that out a little bit more. But it kind of goes into sort of this first topic, a brief perspective of infectious disease ecology. So I always like to start, whenever possible, coming in from left field. And the longer I've been an infectious disease doctor, I haven't necessarily gotten smarter, but I've definitely started thinking about infectious diseases differently. And the more time I think about infectious diseases and effective antimicrobials as a stewardship person and where these diseases happen, the more I think about the things we don't talk about as clinicians often, and the things that we don't appreciate happening that cause infectious diseases to occur in different populations. And this is just a nice paper that came out in 2015 in Science, which I thought illustrated this topic just nicely. And I'm not going to go into great depth about this because I'm not an infectious disease ecologist, but it's a nice place to sort of start thinking about infectious disease. And this is just a series of examples. I'll just run through them briefly. So this is obviously a wild ursine, or excuse me, not ursine, but bovine. Can be used in wild, but also used for interaction with humans. And they get a bovine tuberculosis. And what's really interesting in some data out there showing that bovine tuberculosis can be driven by other infectious diseases that they get. So they actually get potentiated bovine tuberculosis with other specific infections. More in the human realm, this is a campaign done in Bolivia where they went in and did mass eradication of Ascaris infections, so that's big roundworms that kids can get. And what they saw subsequently was a large bump in the number of Giardia infections as a result of this. So sort of giving you the sense that, infectious diseases aren't all by themselves. They're not just even one organism and a single host. They're interrelated in ways that we don't really understand. So that's a nice human example. This is another example of tick-borne encephalitis, which affects humans in different parts of the world, particularly in Europe. And what's really interesting here is these tick-borne encephalitis, if you go back and actually look at the ticks that are infected, and the mice on which they feed, it's basically these yellow-necked mice, and it's only the males, particularly, are the major driving factor. So about 95% of all infected ticks which cause the disease feed on 20% of the mice that are out there, which are all males of a specific species, which is just kind of interesting to think about, even like whether it's a male or a female that the tick feeds on is one of the major driving factors for outbreaks in these settings. This is, obviously doesn't clue you in here, but this is the SARS outbreak. And what's really interesting in this perspective is these super spreading events where a single individual was responsible for massive networks of infection going out from there. And so you can see that, here's this one person, 1, 2, 3, about almost a dozen people who each themselves went on to infect maybe one person. But it was probably a combination of both host effects, but also where they were, in a hotel room, it was really being exposed to lots of folks. You can see these super spreading events are really what triggered the whole SARS outbreak. Moving back to animals, in Europe they had a large influx of these red crayfish, which are not indigenous to the area, but are susceptible to a crayfish plague. And what's been really interesting is the native crayfish are not susceptible to this. But what they started to see is introduction of this plague into the native crayfish, because the numbers of the red crayfish are so high now that they're getting breakthrough infections. So just showing, like, even if you're a resistant population, if you bring in a sensitive population and you bring up those numbers high enough, you start getting introduction of disease and spill over into the previously resistant population. And then the last one is one that we don't see around here, but Borrelia burgdorferi, the cause of invasion of Lyme disease, which is really the result of these ecological kind of trapped areas, mostly within the eastern United States, or other parts of the world where mice are overpopulating these small areas. There's other small animals like raccoons and skunks. People often think about deer being the big problem, and they're actually not. It's these sort of small and middle-sized animals are the big drivers, but they're trapped in these small forests that are surrounding these neighborhoods, which is really where all the exposures are happening. And that's all a result of sort of our 200 years of history and how we've populated that area. So this is, again, I don't want to spend a lot of time on it, but I just wanted to sort of introduce this idea that we don't really understand what we're doing when we are, treating diseases, moving species around, introducing new infections into new areas. And I think this is an area in which infectious diseases, at least on the research end, is probably moving. And I'm going to actually come back to this a bit when we talk, if we have time, around the microbiota.
There's one thing happening which is related to the male mice example, which
Yes.
doesn't have to do with infectious disease, but I found fascinating is as with global warming and water temperatures increasing, sea turtles now are almost 100% female. They're very sensitive to the water temperature, and I just wonder if anybody understands that biology. Just as we drive the climate, we change something totally unexpected.
And we know that crocodile sex is driven by the temperature in which their nests are held. And so it's maybe a similar so at the egg stage that they are chosen. So, and again, when I have time to sort of think about infectious disease and what I'm doing to my patients, particularly around the topic of antimicrobials, or when any of us use antibiotics in a patient, the perturbations, the way that we're actually engendering in these folks, is probably much larger, and the impacts are much larger than we probably think about. So I talked about, the last couple of years, Zika. A few years ago, obviously talked about Ebola. I just updated you a little bit on influenza. This year's pathogen, sort of a novel pathogen, is Candida auris. Have you guys been hearing about this? Candida auris, so a couple folks. So this is an emergency notification with the CDC published in June of 2016. And what I'll just briefly, I'm not going to read the whole thing, but you can read it. But international healthcare facilities reporting Candida auris, multiple sites, a multi-drug resistant yeast causing invasive healthcare-associated infection with high mortality. Some strains of C. auris have elevated minimum inhibitory concentrations to the three major classes of antifungals. So when we think about that's our three antifungals that we use, and this is a pathogen that's showing resistance to all of them in general, thereby severely limiting treatment options, requires specialized methods for identification, can be misidentified as another sensitive agent. And in 2016, they'd known there was this one in 2013 as part of ongoing surveillance. And the point here was experience outside the United States suggests that C. auris has high potential to cause outbreaks in healthcare facilities. Given the occurrence of C. auris in 9 countries on 4 continents in 2009, CDC is alerting U.S. healthcare facilities to be on the lookout for C. auris in patients. So this was first described in 2009 in Japan from the ear of an elderly patient in Japan. There was probably, going back, one other Iceland in 1996. But what was really interesting about this emergence was that it happened on several continents almost simultaneously. So there was, with very little evidence, or actually no evidence, of cross-continental transfer. And actually genetic evidence, which I'll show you in a minute here, of sort of distinct clades arising almost at the same time. So really, really interesting. And obviously a lot of concern given that, a lot of Candida species are susceptible to at least one, if not several, of our antifungal agents. Candida albicans, quite typically sensitive. They're easy to use oral and IV therapies being the most common. So why is it a problem? It can cause bloodstream infections, it can cause death. It tends to hit folks in hospitals and nursing homes. We've seen this in outbreaks in the United States, mostly associated with transplant units or people with a lot of immunocompromised situations. And of the limited number of patients, about a third of them were dying. It's often quite resistant to therapy. It's becoming more common. It's spread quickly in more than dozens of countries now. As I mentioned, it can be difficult to detect, and if you don't have a lab that really knows how to do Candida species detection, it can be misidentified as another species, and you may think that you'll be able to treat it. And as I mentioned, it can spread and seems to be causing a big problem. It can also colonize folks and spread without even knowing it. Right now, the CDC is recommending if you do have a case, to obviously isolate that case, sort of like we would treat with like an MRSA or highly drug-resistant gram-negative rod, but then also to do screening of any contacts and to think about what you're going to do for them as well, because simply being colonized and being a potential vector for transmission is a deep, deep concern. So, as I was mentioning, this is just a couple different studies published in 2017 here showing the basically 4 big clades. And again, what's really interesting is that these emerged almost simultaneously. And as I pointed out, if you thought this was a single kind of emergence in Japan and then transmission across the world, as we saw with Zika, with Ebola, with influenza, and so forth, that's not what was seen here. We saw basically simultaneous emergence of several different clades in different countries. So this is the India-Pakistan clade over here, South African clade, Japan, South Korea over here, which was the first one described, and then Venezuela down here, so South America. And here they're sort of breaking it up into sort of similar groups here: Venezuela, India, Pakistan. They have one here intermediate between South Africa and India, the UK outbreak, and then the South Korea, Japan one here. And you can see that this is the species it's most closely related to, Hemulonii, which is not something we tend to see, but is one that can be mistakenly identified as. And so this is fascinating because going back to my disease ecology sort of thinking, not being a disease ecologist, this is kind of amazing. And I don't think we have any idea why this particular pathogen has arisen on multiple continents within a couple of years of each other, after having zero, really almost no infections ever in the past. And also carrying all these mechanisms of drug resistance. Really quite fascinating. So this is going to end up being a problem at some point. This is a map that hasn't been updated since November from the CDC, looking at where there's transmission of multiple cases of C. auris throughout the world, and I guarantee you this is underreported right now because of those potential misses. Obviously, Japan has had a case, South Korea, through India and Pakistan, I just mentioned those. The South African clade has been described, I'm sure, is in other places there. The Venezuelan clade down here, I'm sure there's been additional cases, and then throughout North America. And you can see this is U.S. C. auris cases linked to healthcare stays in these countries. So there have been some transmissions, but or movement of folks, but predominantly causing our North American ones. But really a fascinating story. And just to point out, in the United States, we've had outbreaks of these, mostly in the East Coast, mostly in the New England area. You can see here in dark blue, it's 101 or more cases. So again, if I go back a few years, zero, none, no one even heard of C. auris. And now we're seeing 100 plus cases in the United States, and some states more than that.
Is it possible the organism was already there, but it wasn't pathogenic, and it somehow changed acquired some pathogenic factor?
It's possible. You know, it'd be interesting to think about why a yeast, because there's about 150 different types of Candida out there, and only about 10 or so ever cause human disease. So it's clearly not something that they want to do. You know, it's an uncommon trait for Candida to infect humans. And in this, this issue of the host populations that we most see Candida infections in, I mean, the vast majority, if not all, aside from folks who are getting TPN, who usually have another medical illness, are immunocompromised people. I mean, think about thrush to candidemia. These are people who usually have a port or a line in place, who have, immune systems that are been wrecked by chemotherapeutic agents. We see obviously people with HIV/AIDS in the mouth, but that doesn't tend to invade. So it's really, really unknown.
We've been pressuring the organisms with antibiotics into their current state, but we've never had multiple antifungals to push the funguses. Do you think it's just selective pressure that we're applying to these organisms?
You would think that would be possible, but you know, it would be much more likely for like that to emerge in an area and then see it spread, like we've seen with many other NDM1s and MCR1s, these other genetic mechanisms of drug resistance that we've seen emerge, as opposed to this sort of simultaneous emergence. One, two, I don't know as much about antifungal stewardship. I don't really deal with a lot of fungal infections at Harborview, but the tonnage of antifungals that we use is, I don't think is anywhere near what we're seeing with antibacterial use. For instance, and I'll get back to this if we have time, like around antifungal use in animals. Like I don't think antifungals are a big player, but I actually need to go back and look. But it's certainly in humans, antifungals aren't being used in the same way, unless you're seeing something that I'm not. So this is here. It's something we've got to pay attention to. Our micro labs are paying attention and looking closely for both markers of resistance, but also clear identification of this new pathogen coming out of the world. This is why, you know, ID is so much fun for me and interesting, because every time I come and talk to you, there's something new pathogen to talk about. Okay, shifting gears, the topic I keep not getting to. So, Clostridium difficile. Talk a little bit about stool. As I like to say, ID doctors, my whole life is sex and stool. You know, that's all we deal with.
Freud would have something to say about that.
Well, it's a discipline. Sorry, you know, I don't know what it is. It was there before me. But I feel comfortable talking about this. So, what is Clostridium difficile? It's fun to think about sort of the basics, because the basic biology of Clostridium difficile informs many of the problems we're having with C. difficile right now. And the issues around C. difficile actually touch on some really cool science that's just emerging now, and I think goes back to the disease ecology. So C. difficile, we think, you know, can be boring. Another patient with C. difficile, give you know, metronidazole or vancomycin, get better, hopefully, and then it's all done. But it's actually, I would argue, is way more interesting than a lot of us give it credit for. It's actually, to me right now, it's one of the most interesting bacteria to think about. So what is it? So it's a gram-positive anaerobic spore-forming bacteria. It's a member of the Firmicutes family, which is, Firmicutes populate our guts in the billions of organisms. It lives as two forms, a vegetative, so that's the disease-forming form, the replicating form, and the spore form, which is, you know, kind of like that hard nugget, and that makes it hard to clean, right? When it's in the spore, metabolically inert form, it really needs to be hit with bleach or something similar to clean, to kill off in hospital settings or other settings. Spores are very O2 tolerant, so they're very hardy. They can live out on spaces. They can float all over the place and live on keyboards and be picked up and ingested. And they're intrinsically drug resistant. So people don't often think about C. difficile as drug resistant, but it definitely is. It's often fluoroquinolone resistant. It's often clindamycin resistant. And that's one of the key things around why we think of this association with clindamycin use in C. difficile, is because we're killing everything else off, but C. diff is clindamycin resistant, so basically just selecting. It's not Clinda's driving C. diff. We're just selecting for it. The same thing happens with fluoroquinolones with certain strains. So the basic biology here is why this is so persistent. The spore form, it gets all over the place. It's really hard to kill. It lives in air, no problem. So that's the basic issue there. But there's some other things around this too. So just to take you back in history a little bit, never thought you'd be talking about this, I'm sure, when you came here this morning. But back in 1935 was when it was first described in healthy neonates. So it was first called Bacillus difficile. The term difficile comes because it's very hard to culture, which is, again, an important biological issue because that is relevant to how we test for it. For those of you who have tested for C. difficile, most places these days are using PCRs because you can't just culture it like MRSA or gram-negatives, which has a whole host of problems, you know, both good things and bad things around the problem. So it used to be called Bacillus difficile, and I said from healthy neonates. So no one under 1 year of age should get tested for C. difficile, and you could even argue you can stretch it up to maybe 2, because babies normally have C. diff in their colon as part of their microbiotic sort of initiation. It's part of their normal biogenesis. And they also don't have the receptors for the toxins that cause disease in adults. So babies can have C. diff in their colon, and that's normal, and they don't get disease. They're totally fine, which is fascinating. This is a bad disease in adults most of the time when people have it, we think. And it has no impact when you're 6 months old. And it's actually normal to have it there. So going back to that disease ecology theme, it's fascinating to sort of think about. Are you starting to get interested a little bit?
Yeah.
Kind of interesting, right? But it wasn't until 1974 that there was this description of clindamycin-associated colitis. Not C. diff, but just this colitis. That when people got clindamycin, they started getting these episodes of colitis and diarrhea, and some of them did quite badly. And it was in 1978 that John Bartlett at Hopkins basically linked the pathogenesis of C. difficile, the presence of C. difficile, with antibiotic-associated diarrhea. So the clindamycin-associated colitis sort of fell in this bucket of antibiotic-associated diarrhea. People got worse, even off antimicrobials, and Bartlett basically recognized that C. difficile was the thing that linked those two things together. Subsequent years, we spent a lot of time talking about basic treatment. We treated with metronidazole for years and years and years. There wasn't really a lot of basic understanding of this. There's this big problem with recurrence. Somewhere between 40% to 60% of folks who have a bout of C. difficile get it happens again. Once you have that first recurrence, you're 60+% of them are going to go another one. The next big historical topic was in 2005 when the description of a big community outbreak associated with this NAP1 or ribotype 027, which had a third toxin in it. So C. difficile typically has toxin A and toxin B, at least the pathogenic kind. Toxin B is the main driver of disease. And this one had a third toxin called binary toxin, which potentiated the effects of the other toxins. And the other big thing around this was this community acquisition. People out in the community without really any healthcare exposure coming in with C. difficile disease and needing to be treated. And this has happened all in Quebec. So those are sort of some of the big historical elements around this. So just a bit more about the basic biology. It's very genetically diverse. And this is one of those, again, coming back to the theme of today's talk, is that, we, as clinicians, we are appropriately thinking about MRSA or E. coli as one big group, right? We hit them, in someone who's seriously, we look at drug sensitivities. But one of the things that's been really interesting to think about, and is certainly proven out by the studies, is that all these bacteria are enormously diverse, and there's lots of different ways to split them up into families, clades, what have you. And C. difficile is no different. I'll show you a snapshot of how different it can be. Is all over the place. There are pathogenic toxin-producing strains. Some have 2 toxins, some have 1 toxin, some have 3 toxins. Some are non-pathogenic, so people can have C. diff in their colon and have really no toxin production or no toxins at all. The 2 key ones we care about are toxin A and toxin B. Most of the tests out there for the PCRs are looking for toxin B because without that, we don't think people can get disease. And these obviously are involved with colonic epithelial cell injury, and they stimulate a lot of inflammatory response. They don't typically go out to other areas outside the gut, although I have seen a patient or two with C. difficile in a wound. But we don't see C. difficile bacteremia. We don't see transit from the gut into a wound. It's usually direct inoculation, but pretty rare. As I mentioned, toxin production leads to inflammation, which again is an emerging theme in infectious diseases. The disease outcome is probably associated with the host's immune response. We've learned, people talk about precision medicine all the time. I mean, in ID, that's what we do all the time, right? We're always thinking about the specific bacteria that's causing that disease in that person as a sort of a precision approach. And this, idea of how a disease manifests itself probably has a lot to do with the patient's immune response, right? Their inflammatory response, sort of how they're set up genetically in terms of their prior exposures. I'll come back to this a little bit because I think there's some emerging data out there, including a candidate who may be coming over to the Hutch in the next year or so, professor there, and looking at actually maybe a lot more of this has to do with the specific strain or the combination of different bacteria in a person's gut is actually the key driver for disease as opposed to the host's necessary inflammatory response and how they're keyed up, or maybe some combination of both. So this is just a snapshot of the different ribotypes. Now you can't see all this, but basically what I want you to see are the different colors. So each of these different colors represents a different ribotype of C. difficile. So when, again, if any of you are getting a PCR, some of the commercial platforms will tell you whether it's C. diff there or not, looking for the toxin B gene. And some of them platforms will give you whether it's a ribotype 027. So that's the ones associated with these big outbreaks in that third toxin, the binary toxin. So they'll tell you whether it's 027 or whether it's everything else. And one of the interesting things here is that we have no idea how diverse the population of C. difficile is in, for instance, Washington State, because our tests don't give us any idea of that. And if you look across different continents, the pattern of diversity varies quite a bit from some places where it's all one to other places where it's really a mix of different strains, some of which we don't really even understand. And you look across different areas here, you can see just the proportion of all these different ribotypes happening on different places. We've had discussions with the CDC because in Washington State we actually have a higher than average C. difficile rate, but we actually have a lower than average antimicrobial use rate as a state. And so there appears to be a disconnect because we often think about C. difficile as being driven by antimicrobial use, both appropriate and inappropriate. And so one of the things we've been just talking to them about, because they have a lab at the CDC that can look at these things, is whether they start looking at strains here in Washington State or in the Northwest to see whether there's something different around the ones that we're seeing here that may be impacting that disease outcome. So just fascinating to think about the diversity of strains that are actually out there and what we do and do not know.
What is ribotype? What are you measuring there?
I think it's basically just looking at the ribosomal diversity. So when we think about the disease process, we have this sort of simplistic, mechanistic way of thinking about C. difficile disease development. So you have a human being who has a gut microbiota that's in homeostasis, and that gut microbiota is really unique to that person, right? We think about the fingerprint or other analogies as a key driver. The gut microbiota, as many of you have either seen in popular press and read in literature, is now being linked to a huge number of health statuses, from hypertension to autism to schizophrenia to obesity, right? Huge numbers. And both the animal and human data is quite compelling around the important role of this. Now people are talking a lot about the gut neuroaxis and inflammation in the gut and its relationship to stroke outcomes, which is some data that I've just seen recently. Really, really fascinating information that I think we're just on the tip of understanding. So, but all of us have this gut microbiota. We have an antibiotic exposure, sort of the first hit, that causes a dysbiosis, so some sort of change in the quantity, the diversity of the bacteria that lives in our gut. This model has C. difficile exposure then happening. I would say it's arguable whether this happens up here or this happens there. The order of this is not really well known. And then because of that dysbiosis, you can get introduction and overpopulation with C. difficile, a toxin-producing strain, which causes persistent dysbiosis because it's now filling up all those spaces and all those niches which were previously occupied by your healthy bacteria. A lot of inflammation, release of toxins, and Clostridium difficile infection. What they have over here is this effect of fecal microbiota transplant, which I'm going to talk a little bit more about, that restores the gut microbiota. I'll just make a couple of quick points here. Is that not everyone who has C. diff in their colon and or gets antibiotics gets C. diff. I'm not sure if I mentioned this last year, but we're doing a study or a project at Harborview where we're screening everyone who comes in our trauma surgical ICU and our medical cardiac ICU for C. difficile colonization. Now, it's not a super sensitive test, it's just a rectal swab, unlike C. difficile, unlike doing the test on stool. But about 5% of everyone who comes through our doors at entry, day 0 or day 1, has C. difficile in their colon, right? And from our small data set, about half of those folks go on to develop disease following antibiotic use, but half don't. And so, again, there's people out there in the world, and maybe even people in this room who have C. diff in their colon and are perfectly fine. And why that's true in some people and not others is totally unknown. But clearly this is a pattern I think is reasonable in terms of a basic mechanistic idea here. And this idea of fecal microbiota transplant, which I would argue, I'm actually a fan of this. If I had bad C. difficile, I want a fecal microbiota transplant. But I will tell you that we have no idea what that really does, right? If we really know that microbiota is associated with things like hypertension and autoimmune disorders, there's some anecdotal data around the resolution of things like rheumatoid arthritis following a fecal microbiota transplant and the onset of immunological disorders after, or autoimmune disorders after a fecal microbiota transplant in some case reviews. Fecal microbiota transplant is an organ. It's like a blood transfusion or putting a liver in someone. It's not just without any risk. And we have no idea really what those risks are. Because if they are associated with things like obesity, hypertension, schizophrenia, or outcomes in stroke, right, and we're moving fecal microbiota around, we're not really consenting for that when we do it, to be clear. So I'm going to talk a little about FMT. Here's our little, this is the way we sort of think about FMT. You know, we have our happy stool. I'm not sure if this actually will work. I had it animated, but it's not working. So we have our little fecal warrior here moving through all this C. difficile, right, and repopulating with a healthy someone else's microbiota and their microbiome. And it does work. You know, I'd say 9 out of 10 patients after one, probably 98% of patients after two, have resolution, no recurrence. And this year, recurrent disease is a big problem. I mean, if you're 75 years old, you just got through your pneumonia, and now you got C. diff, and it recurs out in the outpatient setting, you're not eating, and you're on metronidazole, which makes everything taste like metal, and you're not eating, and you're not getting your energy back. You know, it's the cascade of effects that and put people in nursing homes or worse. And if you come in there and get this, and you're done, right? 24 hours, you're having normal bowel movements, and now you're eating again, you're off metronidazole, you're feeling good, you can recover and do all your rehab. That's pretty remarkable. So we have this balance of a tool that seems to work really, really well, but we have no idea what its true impact is on an individual in the long term.
Is there a difference in success between the capsule that they've now developed versus just stool transplant from patient to patient?
No, so the early data around this was really interesting in implying, and this just goes to show you why you need a lot of data over a long period of time to really come to any understanding, is that the initial data showed that fresh stool from someone who is related to you or you live with, like a spouse, seem to be more effective than others. That then was shown not to be necessary with the Open Biome Project, which I'll touch base on, looking at someone else's stool, somebody you don't know, seem to be equally effective. And now what's been affectionately known as crapsules from the same company, appear to be equally effective. So the things we do know is unrelated stool's okay, frozen stool's okay, and the capsule method seems to be okay. The issue with the capsules is you have to take a lot of them, right? You have to, I think it's like 20 or 30 of these things. So you have to sit down at once and be like, now they have a special coating so they can get through the stomach, but they seem to work really well. And then you don't need to deliver FMT, you need a nasogastric tube, an enema, or a colonoscopy. And so you can see the benefits. You just come to someone's office and
Give you 20 drops.
Yeah, and maybe in the future that's how we fix your hypertension, right? And make you skinny.
Is it known why neonates, I presume when you told us in the beginning of this story, neonates have it and then it disappears. Most of them don't carry it after age 2. So whatever mechanism does that could be very effective if you knew what it was.
It's a great point.
Yeah.
And I don't think we understand sort of the, is ontogeny the right word? Sort of that, how we develop our gut microbiota, right? We come out sterile. There's actually, I just saw a quick article yesterday looking at taking babies who are delivered by C-section, who don't get exposed to bacteria via birth. And actually, scientists are now taking vaginal microbiota, introducing it into the babies who are getting C-sections. And then they're following them to see what their outcomes are like in terms of their microbiota and potentially disease development. Because it's really fascinating to think about how we get introduced to our gut microbiota, right? Because we're sterile, and then you get some come through the vaginal canal, and then you start breastfeeding, so you're dealing with skin flora. But like, how do those really hardy, I shouldn't say hardy, but the very fragile anaerobes get in there? Like, are they coming through the hair follicles, like around the breast tissue, or is it the dirt they're all eating, or just laying in, licking each other? I don't know where it all comes from, but it's really fascinating to think about how does it happen, because in bulk form, we kind of understand that it's very similar, right? There's anaerobes and the C. diff, it sort of marches along, but the diversity with each of those layers is very different, because we end up with a different picture going forward. So it's really very, very interesting. But that's a good question. So how it clears out, we don't know. I don't know. So talk a little bit more about FMT, a history. I'm okay, thank you. Good, yeah. So actually, this goes back a long way. So back in the 4th century in China, in the Handbook of Emergency, there was a recommendation to ingest feces to treat gastrointestinal problems. Another physician in the Ming Dynasty in the 14th century had prescribed people fresh, fermented, dried, and infant-derived feces. These were called yellow soups at the time. In the 17th century, the vets started practicing called transfaunation, where they take feces out of one healthy animal and then put it into a sick animal. And actually, vets have been doing this for a long time. They do it; it's not like a big deal to them. You ever seen a vet glove? You know, we argue about those little gloves. Vet gloves go up to like here. They're like, if I could get people to wear those in the hospital, we'd be all set. In World War II, there was these anecdotes about Bedouins recommended German soldiers in North Africa to ingest warm camel feces for dysentery with good results. I can't imagine it made you feel good. I mean, just give me something else. I don't have dysentery now, but I have something else. maybe SARS. And then in 1958 was actually the first description of humans. Remember, back before we knew C. difficile caused C. difficile disease, this clindamycin-associated disease, in 1958, a fecal enema of Pseudomonas colitis, which is pathognomonic for C. difficile disease. So we know this was C. diff. Back then, had good results. And then in 1983 was the first study looking at FMT, which was also effective. So this goes back. This isn't something we've just been sort of decided to do recently. It has sort of a track record in animals and humans, and effective. And there's pretty good data now. There's a solid indication for recurrent CDI if you look at the guidelines. There's good data now for safety in immunocompromised patient populations like bone marrow transplant and others. This doesn't appear to cause, invasive infection or some other bad outcome in those folks. There's some data for FMT in kids. There's emerging data for use in severe CDI. So I'd say a lot of people are really interested in using this in the acute care setting, maybe even with primary infection, particularly in patients who are already ill, or more, many of my surgeons are actually quite interested in using this in our ICU populations. The data's not great. The downsides we don't think are really strong, but this issue of using it primarily is certainly thinking. Going back to the capsules, right? If you're in the hospital, you got pneumonia, and you develop CDI, and you're still giving antibiotics, maybe taking 20 or 30 capsules might be okay, right away, up front, rather than getting 2 weeks of metronidazole or 2 weeks of oral vancomycin.
There was a doc back in the Midwest, and I can't remember his name, but he took all these people with autoimmune diseases, and he would sterilize their guts with neomycin, and he would repopulate their gut with his organism of choice.
Yeah.
And the statistics never showed that it was great, but the people who got cured actually got cured. So it was very weird data, though.
Yeah, I mean, it's, and I think that's in other diseases. The big thing where people are really interested in using this is IBD, inflammatory bowel disease. I mean, you're right in the gut. Let's change the microbiota. And the data really hasn't been that compelling as to whether it has a big impact. And I think a lot of it has been more like what you're saying. Like, they do it to, a dozen or 2 dozen people, and like, one person gets better. So it seems to be good. Like, hey, this is, they had a bad autoimmune disorder, now it's gone. But the others, it doesn't. And so we're not really sure where it goes, but I think people are very actively looking at this as a tool, as a treatment in inflammatory bowel disease with the hope there. There's actually a really interesting New York article on this, I think last year. A whole big thing around doing this. And you can, just to be clear, you can get this stuff off the internet, right? You can buy microbiota off the internet. You can do it at home. When the FDA actually kind of put a bunch of barriers in around this several years ago, and what you saw people doing was just doing rectal enemas at home, because there's directions on how to do it on YouTube. It's not that hard. I mean, just quickly, you just take stool in a special blender, you blend it, you strain it through a coffee filter, and that stuff that comes out, that liquid, is what you use in the enema, and you just do a retention enema for a while, hold it for as long as you can.
Can you get crapsules in any pharmacy now?
No, you cannot, unfortunately. So I'll talk about that in a minute. It'd be nice. At Harborview, we have a special fridge in the pharmacy. No other drugs are in it. And that holds our material, our capsules. And so we're looking at how to expand on this, because if someone's coming, why do you have to be seen by some specialist to do it? Just get it done.
What about disease transmission with that, like Jardier or something else?
Yeah, so when one of the other big barriers to this when it was initially launched, right, is that, say, I had C. difficile and I wanted a donation from my family, was that the guidelines had a whole list of testing, and the testing is actually far more extensive than blood transfusion, right, because you have to look for things like Giardia and all these other diseases that we don't see in blood, and that cost was not covered by insurance. So it was like $2,000 worth of testing of the donor. And that was a huge barrier to folks, right, to donating and then getting treated. And so the testing is actually quite extensive. And I think I'll come back to that question, though, because there's answers to that. So just to quickly show you some of the data here in transplant. So this is looking at, sorry, this is working great. So here's percent cured without relapse. Here's the first infusion of donor feces. Here's the infusion of donor feces, and these are recurrent cases, outpatient. Here's oral vancomycin, which as far as we know is the best treatment for C. difficile. And here's vancomycin with bottle lavage in the fourth column. And you can see in any comparison that FMT is vastly superior to our current treatments, right? So if you have recurrent CDI, do you want to be in this group or that group? I mean, it's pretty straightforward. But if there's any barriers, cost of donation, getting a colonoscopy, what have you, just having someone who does it, it's actually not that easy because you don't get paid for it right now, right? The reason that gastroenterologists tend to do it is because they can scope you, infuse the donor feces, and they can charge for the scope, right? So that kind of takes it. So the data is really, really good. Here's just another study looking at the diversity of bacteria. That's the Simpson's reciprocal index, which is just a different way of looking at the diversity of bacteria before or during C. difficile infection and after, which goes back to our sort of mechanistic model at the beginning. So here's a donor diversity up here, so someone who's healthy. Here's a C. difficile patient. This is a group of patients. And looking at the very, very low diversity of colonic bacteria in the setting of C. difficile, right? Which is really, that's the disease. It's a disease of destruction of the microbial diversity in your gut. And then here's patients after an FMT. So you can see the diversity of their gut, colonic gut microbiota are basically back to the way they were. But again, I would make the point that this is not the same as these people were before. They are got a different microbiota there. And it's really, truly a transplant. So it's just fascinating. So your point, open biome. So once we recognize that you don't need someone you know, there's actually some grad students at MIT in Cambridge, Massachusetts. One of them had a friend who got bad C. difficile. He's like, why is this such a hassle? And basically set up a stool bank. It's called Open Biome, where they have a group of donors who are all screened, so you don't have to do the repeat screening. The cost now drops. And for actually pretty low cost, you can get these 250 or 500 ml pre-screened vials of stool. And you can aliquot as you see fit. And this is the same group that also makes capsules, and they're all standardized. They've all been pre-tested. And so we have this in our hospital, Harvard. So you can go downstairs to the pharmacy and get this thawed and infuse it. Nasogastric tube, colonoscopy, or enema. Again, most of ours are being done by colonoscopy. Yes?
Can you have patients bank their own, like the ones that are going to go in the ICU, and then you think half of you are going to get C. diff?
Yeah, so it's something that people have been thinking about. The issue is that even though we talk a lot about C. diff, so at Harborview, we have a lot of C. diff, I would argue. It's a problem for us. About maybe 10 to 12 cases per month. 10 to 12 cases isn't that many, actually. I mean, it's terrible for each person. We can definitely want to get that rate down lower, but considering how many people I have in my hospital at any given time, over the course of a month, the absolute number is not that great. That's a lot of feces to store. But the idea of maybe people who are going into a transplant setting or getting chemotherapy or they're going to be on antibiotics for a long period, like maybe there's a subset of folks. Maybe if you're C. diff colonized, when you come through the door, knowing that 50% of you are going to go on to get disease, maybe we should bank you up front so we populate your gut with your bacteria. So it's sort of like, people do this with blood transfusions, I think, right? You save your own blood and transfuse it later. And so I think that's a really interesting thought. We just don't have a mechanism for doing it right now.
That would eliminate the cost of screening if you just bank your own stool.
Yeah, and so the screening's actually already, these guys have already kind of taken care of that big financial barrier because now I can get one of those and the cost of the patient for the whole thing is like $250, $500. So it's much, much cheaper. And again, you can have the capsules too and so forth. And the whole, and then you probably still have to test. I mean, there's some issues there. Like, what happens if you have something and I give it back to you later on, right? You already have something, and now I've given you your Giardia back. What's the, I don't know, right?
Point taken.
No, but people know. No, it's a good point because people are talking about that. Like maybe you do want to do this. So I just want to make a couple other points here around antibiotics. So we, again, thinking about this basic mechanistic idea of how C. difficile happens. Am I putting you guys to sleep? Is this okay?
No, it's
Okay. So one of the things I mentioned, it comes in this vegetative and the spore forms. And spores are the ones that transmit disease. And again, I always like to point out to folks that this is a fecal oral pathogen that is spreading in our hospitals. Right? We don't have Hep A, we don't have cholera, but somehow we have this fecal oral disease spreading around because the spores have to get into your mouth, right? Through your colon, populate your colon, vegetate, make more spores, get out of your rectum, and then back into someone else's mouth, right? So this is happening in our hospitals for reasons that I am stunned by.
And adult homes and nursing homes.
Absolutely, and the community.
Yeah,
absolutely. So the dormant spore gets ingested, starts germinating, and becomes a vegetative cell. And then that vegetative cell generates toxin. It starts sporulating, makes more spores, and they go on here. HPI is hours post-infection. And what I like to point out here is that I don't think really, as clinicians think about C. difficile, we often think about it as sort of something that happens like a week into hospitalization or something like that. And what's really interesting, if you go and start looking at the biological data that's out there, is that the transition from a dormant spore, so ingestion, to vegetation and toxin production may be in the form of hours. And this makes me start thinking about it, is that maybe it's more of an acute or subacute disease process than we think about. So maybe it's a couple days into hospitalization, maybe is all you need to get exposed and develop disease. The other thing I like to point out is that antibiotics all by themselves probably aren't the only driver of this, right? Certainly colonization, exposure, and so forth is really important. But antibiotics themselves cause far more change in our guts than changing the diversity of our microflora. And I would say the biggest part of this is these all of the gastric and bile acids that we use for digestion are also profoundly changed with the use of antibiotics. And often this change in the acid pH and types of acids that are present actually are one of the key drivers or the key risk factors for C. difficile disease development. So antibiotics have a big impact not only on the microflora, but also the bile acids that we use for digestion. And that sort of recipe of the bile acids, as it changes, may also be a key driver for C. difficile disease spread and disease development, which is really interesting because that kind of moves us away from just antibiotics killing off a bunch of bacteria and you get C. diff. It probably has a lot more complexity to it than we think. So just thinking about bile acids, and it actually starts making me think, because when I think about C. difficile, I think about antibiotic stewardship. We have this association with proton pump inhibitors overuse, and so proton pump inhibitor usage, diagnostic stewardship, because we're over-testing people who don't actually meet criteria for disease. And now I'm starting to think about, well, maybe I need to be a bile acid steward too. Like, are there ways that we can impact bile acid sort of status that would prevent disease development as well? Or use antibiotics and have less impact on our bile acid sort of milieu?
I just want to mention to you, you're not
Yes.
even going to come close to finishing.
No, of course not.
Of course, but so if there's certain things you want to get to.
Yeah, let me finish this story and then I'll be done. And then we'll talk.
You can go to anywhere you want.
Yeah, yeah.
but- okay.
I think it's tradition never to finish.
Okay.
Every time I come here, I never finish.
You have to come back.
Yeah, so
That's why
I
you
have to
come
go
back
back. And I
every
just
year.
pick up where I was last year and put them in the next year. So next year we're going to talk about agriculture and antibiotics to start with. But I'm going to just finish on C. difficile just because, again, I think it touches base. I just want to make a couple more points. Again, one of the big points around C. difficile is that there's a spectrum of disease, and it's not, you start with leukocytosis, you get diarrhea, and then everyone goes on to develop shock and dies. That just does not true. Some people get diarrhea, and that's it. They have subtle signs of disease. And we test them, they have C. difficile, we treat them, and they get better. Other people go on to develop, more profound symptoms, somewhere in the middle. Some people get colitis, some people go on to develop pseudomembranous colitis. Typically, when you get there, you're kind of going to start marching along this path indefinitely. But the diversity of disease presentation with C. difficile is actually quite profound, and we really don't know why that's happening. Now, again, I think a lot of medicine is looking at host factors, and that's certainly very, very important. Why some people develop a little diarrhea or some leukocytosis, and other people, get shock and die from C. difficile. But I think there's some emerging data coming out there that it may have something to do with more about what your microbiota is and the interaction with C. difficile. or maybe other exposures you're having to different bacteria, an interaction with C. difficile and those bacteria in your gut that's driving this disease, and why you get, some people get very, very sick and others don't. So one thing this is sort of just some basic science by this PhD, for his first name, Zacular, down at Vanderbilt. And this is just to kind of introduce the idea that he, in mice, looked at C. difficile and enterococcal infections or enterococcal density in mice, in eubiotic mice, and basically fed them different types of diets. There's been this old link between zinc density, or how much zinc you get in your diet, and enterococcal density in your gut, and potential disease outcomes. And what he basically showed is that if you look at the histological score of enterococcal and C. difficile infections in mice with a controlled diet versus a high zinc diet, just going back to anybody who's a big vitamin person, high zinc diets are profoundly associated with enterococcus overgrowth. And you can actually show this very clearly. That if you can actually select for enterococcus in your gut by taking a lot of zinc. We know this in humans, we know this in mice. So zinc drives it because it's very toxic to most of our gut, except enterococcus. Enterococcus doesn't care how much zinc is there. You get a lot of zinc there. And you can see that enterococcus itself, log 10, is dramatically selected for with high zinc diets. So the reason I bring this up to some extent, I'm not going to spend a lot of time on it, but we know that C. difficile does not form really good biolayers, these kind of slime layers, in any form, including our gut. But enterococcus does. It can form, it can adhere to any place, a little bit of inflammation, a little bit of toxic reduction by C. difficile. You get some area where it's the colonic epithelium sort of inflamed. Enterococcus will lay on there, it will populate, will form a really nice biolayer. And what's really being really interesting that's being shown now is that there's this interaction between enterococcus and C. difficile, particularly in these biolayers, where C. difficile is sticking to the enterococcus as the enterococcus is sticking to us. And it may be more that it's this combination of bacteria in different densities forming these complex structures along our gut that's maybe one of the key drivers for C. difficile acquisition. So maybe it's your enterococcus that's the key problem, when instead of not really the C. difficile introduction that's causing disease. And clearly, and the reason this zinc model is really important is because you can really drive the enterococcal rates, densities really high, and look at the outcomes when you introduce C. difficile. So really, really fascinating. And I'll close on this one. You have a lot more slides. Again, we're going to pick up there next year, so just save those. Just to go back to my point around disease ecology and what we're doing at MMT is unknown, really, is this study in fish. It's always good to finish with a nice fish study. So there's a particular species of fish, I think they're called like killifish, something like that, and they're the shortest lived vertebrates in the world. So they only live the longest I think is 29, so like a normal adult fish lives like 20 weeks, I think, at the longest. And what they did was they took the young fish and old fish in separate tanks, and they took the young fish and took their guts out and put them in the old fish tank. And the old fish started nibbling on them, right? And so we're basically ingesting the gut flora of the young fish. And what they did was increase their lifespan quite dramatically. So these are the normal fish groups here. So their normal lifespan around 20 weeks or so. And then they took the ones that were fed the young fish stool, and look what happened to them. They lived longer, dramatically longer, time after time. So these are large groups of fish, obviously. And the basic idea here is that if you feed young stool to an older fish, the older fish live longer than the healthy fish, normal healthy fish. And so the impact of transplanting microbiota, I mentioned all these stories around, hypertension and the gut neural axis, and obesity and autoimmune disorders. This is impacting lifespan, right? Time after time. You can repeatedly increase the lifespan of these fish by like 20% by changing their fecal microbiota. So when we are transplanting people, it makes me think, whose stool do you want? Right?
Baby stool.
You want,
Grandchild.
maybe not baby, right? You want the right one. You want like a good healthy teenage stool, right? It's like a vintage. That's the stool you want. And so when you talk about crap stools or FMT, who's donating the stool to you may be much more important than we think, both in terms of our other disease outcomes, but maybe even things like lifespan. So,
Well, the company that you showed us, the guys at
Open Bio.
MIT,
Yeah.
Yeah, I know.
who did I presume that's an FDA approved product?
FDA's sort of been a little hands-off of this.
Right?
Yeah, they can give you all the breakdown. So they have like a group of 20 or 30 donors who do it reliably, and they have been all pre-screened, and they're actually following. They're trying to follow outcomes in different cohorts of donations. So there you go.
So at age 50, when you get your first colonoscopy, you should
Get a 20-year-old.
Yeah.
And then
Get
you got
your grandchild to donate.
There you go. That's something we're thinking about. 20% increase in lifespan.
Well, you've definitely left a lot of material for next year.
Well, it gives you something to read about.
One less. Is there any Zika anywhere around the world? Pockets
It's still going around, but the outbreak situation's definitely quelled. I mean, the issue is once you get Zika, it's not really a big problem, and the people who it impacts is really, it's really pregnancy is the biggest problem. So I think many young people who are now pregnant or going to get pregnant have been already exposed in places like Puerto Rico and South America. So
But like that local transmission in Dade County, is that
not a
gone?
problem. Sorry, it's gone away.
And do you know why it went away? I mean, seriously, is it
I think
spread?
I think it's just immunity. So people become immune. I think larger populations, and I think the introductions in Dade and stuff like that. I mean, think about all the other chikungunya, dengue. I mean, we get every once in a while like a little breakthrough, and it may happen again. But right now, I think and that's at a really high density. Was it able to break into Florida and Texas? And right now, those densities just aren't the same. And so, our insect control efforts in the United States I think, actually work pretty well.
Have they looked at just changing the pH of the bowel to see if you can combat disease with that instead of using antimicrobials or stool transplant? Just give the patient something to raise their pH and change the balance?
Yeah, it's a good thought, and I don't know. I wouldn't be surprised if someone's looked at it, but I don't know any data. All I care about is the bugs. But it's an interesting thought, yeah. So thanks for your attention, guys. Have a great year.
Fascinating presentation.
Yeah, keep your eyes out for Canada Awards. I'll be here at some point.
Well, I know who to ask.
Yeah.
Do you suggest if we get these growing?
Oh, no. I think the recommendation now is any invasive fungal infection, any Candida or something similar, invasive that they get a species. Yeah.
When you head down.
Yeah, the U doesn't know what they're doing. They're all over it. So anybody who goes to the U will get speciated.
Yeah.
Great.
I know.
Her sister's dead. We had such a good weekend.
Yeah, it was great.
Yeah. And I think that would be,
Sunny. I was in a t-shirt.
it's not going to help the patients probably as much there, but I think as a surveillance mechanism, knowing what's wrong is going to be useful. Because I told you, this first starts with someone's ear, right? And the old 1996 one, I think, was another ear in a kid. So it's going to pop up probably in non-invasive before it pops up in invasive. I don't know. We'll see. Or it's going to show up the Hodgkin someone.
What happened? I missed all that. There was.
I have one other question. Has nothing to do with your lecture.
So his announcement can go
Oh,
out.
thank you.
because
Oh, I really appreciate it.
I have a lady who's immunodeficient.
I'm going to Renton.
Okay,
Take it
fair enough.
His file was too big.
Oh,
Francis didn't recognize it.
MRSA, and now she's colonized with Pseudomonas
I
in
called her
her.
this morning at about 6:15.
She's getting IVIG,
I
so
finally
she's
sent
cleared
it
the MRSA,
without the
but
attack.
she hasn't